Good morning, folks, and welcome to this webinar on delivering the vaccine. I'm Chris Eukins. I'm a professor of government procurement law at George Washington University Law School, and we're very happy to be holding this webinar today on delivering the vaccine. In no small part because of those of us who've been watching in the United Kingdom, for example, the first delivery of the vaccines. It's a good feeling to feel like we're at as Winston Churchill would have said, if either the end of the beginning or the beginning of the end of the pandemic. I want to welcome our participants. We've had over 400 registrants from over 28 countries and over 25 states across the United States. I especially want to thank my co-moderators, Amanda Willett from Crown Agents and Desiree Klingler from the University of St. Gallen. And also our supporting co-sponsors, the National Association of State Purchasing Officials and Crown Agents, who have helped us do such a great job in publicizing this webinar. Thank you all very much. I'm going to just go quickly over the ground rules that all opinions offered are the personal opinions of the participants and shouldn't be attributed to their organizations. We're going to have a series of introductions that Desiree is going to help me with. We'll have presentations by the individual panelists, and then we'll have a question and answer session. Please use the chat session. Please feel free to use the chat on the right-hand side if you want to ask questions, either of the panelists or if you want to broadcast them to all the participants in general. I'm going to turn it over to Desiree Klingler, she's a PhD candidate in data-driven public procurement law at the University of St. Gallen. She's a lecturer in law and economics at the University of Hamburg and a former strategy consultant in the public sector. She's very much a rising star in our academic field of procurement law. Desiree, I'll hand it over to you.
Thank you so much, Chris, for the introduction. I will be, as said, co-moderating today's webinar on the distribution of the vaccine, and I would like to quickly introduce our panelist of today, which is Rob Hanfield. He's a professor at North Carolina State University. We'll also be talking with Maribel Ramos, legislative director of the NGA, a non-partisan organization, National Governors Association. Steve Guppy, member of the Crown Agents, an international development organization, and Professor Simon Evenet, professor at the University of St. Gallen in international trade. We will also be having Prashanth Yadav. He works at the Center for Global Development. And as already introduced, Amanda Willett, she is CEO of Crown Agents, and Christopher Eukins, professor of public procurement at the George Washington Law School. So I would like to quickly go over the agenda today. We've already had the introductions, and then we will start off with the United States part of our webinar, which means that we look into the distribution in the United States on a federal and on a state level. So Maribel Ramos will be talking about the issues in this, about the states and the distribution in the United States. We will have Robert Hanfield concluding on different issues and observations on the US issues. And then we will move over to the international part of our webinar, which will be started off by Professor Simon Evenet. He will be talking about entry barriers and export controls. We will then switch over to Prashanth, who will talk about supply chain issues in the distribution in an international area. And Steve Guppy will conclude on that matter, pointing out, excuse me, different issues on international supply chain. And we will conclude with questions from the audience. But as said, you can always ask these questions in a chat. We will take them up and we would address them as good as we can. So now I would like to hand over to Amanda Willett, who will give an introduction to today's topic. She's president and CEO of Crown Agents in the United States, an international development company that helps governments to reduce poverty and improve public health by providing consultancy, financial services, and training. Amanda has worked in international development for nearly 20 years and across many different countries in Africa and Asia. She will now make the short introduction, and I'm happy to hand over.
Thank you so much, Desiree. Really appreciate the intro. And thanks, Chris, for organizing this and inviting Crown Agents to participate. Good morning, afternoon, and evening to each of you. I have the distinct pleasure of welcoming you We are thrilled with the amazing turnout and huge interest in this webinar. As Desiree mentioned, I'm president of and CEO of Crown Agents USA. Crown Agents is a global group of companies. We are headquartered in London, and we have 187 years of procurement experience and expertise delivering supply chain services, tracking and tracing supplies through the last mile in some of the world's most challenging operating environments, from South Sudan to Myanmar. We've got an absolutely packed agenda, bringing together both domestic and US and international perspectives. The news and information has really accelerated over the past week since the UK led the world granting the first approval of the rigorously tested Pfizer BioNTech vaccine and got immunizations underway last Tuesday. Procurement, distribution, access, and equity issues will abound as more vaccines are expected to secure approval and distribution begins to scale globally through both bilateral agreements and Kovacs, co-led by the World Health Organization, Gavi, which is the Vaccine Alliance, and the Coalition for Epidemic Preparedness Innovations. The challenges ahead for the world will be enormous, and our panelists are here to walk us through what we can expect in the weeks, months, and even years ahead. We hope you enjoy the presentations and very much look forward to your questions. Without further ado, I'll hand back over to my co-panelist, Professor Chris Ukins of George Washington University Law School, to kick off the presentations.
Thanks very much, Amanda. I really just want to give a little background for Maribel's presentation in just a second. The panel in the middle of the slide here is what's going on in the United States. She's going to be talking about the CDC's likely approval today of the Pfizer vaccine, and then how things will unfold over the next few months. Just a couple of resources I want you to be aware of are the program materials are Public Procurement International, and I posted in the chat, I posted a direct link to the program page. There are links there to various practical guides, for example, that 2 shots of the vaccine will be needed and what that means. In the US, the first priority is likely to go to healthcare providers and to residents of long-term care facilities, nursing homes, for example. The general US population expects to get a vaccine in April or June. Now, this is the important part, because a big part of what we want to do today is share lessons learned from what the United States is doing and among other nations. So there are two resources I want to highlight for you, both of which are linked at the program page. One, the report you see there from New York State is an example. Each state has its own plan for distribution of the vaccine. Those are very detailed plans following a template laid out by the Centers for Disease Control. And you can, the link is from a USA Today report on the program page. You can just link to any of the 50 states. Also, very importantly, and for the procurement community, and as I said, we have folks from over 25 states here, state procurement folks. On the right-hand side there, you see a report that was published yesterday by the National Governors Association and by Public Health Institute at Duke University, supporting an equitable distribution of COVID-19 vaccines. That report in some detail talks about strengths and weaknesses in the various state plans, and importantly, lays out where the gaps may emerge in the procurement supply chain. So for procurement professionals at the state level, that's a very important report, because it'll help you understand where there might be gaps that the procurement community will need to address in the coming months. With that, I'm going to turn it over to Desiree to introduce Maribel.
Thank you so much, Chris, for this introduction. I would like to introduce our next panelist and speaker, Maribel Ramos, who is a Legislative Director for Health at the National Governors Association. The NGA is a very influential nonpartisan organization that consists of the 50 state governors of the United States. It is an important public policy instrument between state governments and the federal government, and they represent state policies at the White House and other important United States institutions. So with this, I would like to hand over to Maribel Ramos.
Great, thank you, Desiree, and thank you for the opportunity to take part in this discussion today. As Desiree mentioned, the National Governors Association is a bipartisan organization of the nation's governors. And just to point out, I know we often get some slack from territories. We also do represent territories in addition to states. So just want to make sure that we point that out. We provide a venue for governors to share best practices and speak with a collective voice on national issues. Since earlier this year, the work of NGA has primarily focused on assisting states and territories in mitigating the impacts of COVID-19. We have done this through direct technical assistance to states and territories, advocacy before Congress and the administration, and providing an opportunity for states and territories to come together and share best practices, both from governors' perspectives and also their health policy advisors, Homeland Security policy advisors, amongst others. For governors, as you know, their main goal on vaccines is to ensure an equitable distribution and widespread public uptake of a safe and effective COVID-19 vaccine in order to contain the COVID-19 pandemic. Governors are working in close collaboration with local partners and are responsible for what we're calling the last mile of COVID-19 vaccine distribution. This includes receiving the vaccine allocations from the federal government. It also includes managing the systems for ordering, distributing, and monitoring them, and also supporting the administration of vaccines in a number of healthcare and community settings. So this will definitely not be an easy task for governors and states. It's definitely a very complex system that we need to run. And as I speak today, the Vaccines and Related Biological Products Advisory Committee, known as VRBPAC, has convened to discuss and vote on whether or not they will approve the EUA for Pfizer. I know their meeting started at 9 and will run to 3 p.m. today. If they approve the Pfizer vaccine, the federal government has stated that the US will get 22 million doses of the Pfizer vaccine by the end of the year. This means that 11 million people in the US will be immunized due to it requiring 2 doses. If both Pfizer and Moderna are approved, the federal government is expecting 40 million doses by the end of the year to immunize 20 million people in the US. Most recently, the federal government has also said that weekly doses of the Pfizer vaccine will be delivered at 6.4 million doses per week. And these will be allocated to states and territories based on their total populations, rather than what they originally based it on the number of critical population in each state. In addition, I just want to mention that yesterday, the Department of Defense released its initial planning guide on vaccine distribution for military, civilian, and contract personnel. DoD is estimating it will receive 44,000 initial doses. The department will start with a pilot program at 16 locations, 13 in the US and 3 overseas. And for department personnel vaccination, they will prioritize healthcare workers and first responders at each site. So similar to what states are doing. States and territories are definitely relying heavily on information being provided by the federal government to who should receive the vaccine first. In addition, all states and territories, as Chris has mentioned, were required to submit a vaccination plan in October to the CDC, which outlines how they will effectively immunize their residents. As you may know, last week, ACIP met and voted to recommend that both healthcare workers and residents of long-term care facilities be in the phase 1A, first in line for a vaccine. Normally, ACIP will wait until EUA approval, but in order to provide states and territories with time to plan, they put forward the recommendations earlier. In addition, shortly after VRBPAC's meeting today, and if they approve the EUA for Pfizer, then ACIP will meet again to recommend whether the Pfizer vaccine should be given to anyone in the US. In determining who will be in the phase 1A category, states have taken a variety of approaches to defining and estimating critical populations, developing processes or formulas for further refining subpopulations when vaccines are limited. States understand that they need to be flexible and adaptive in adjusting their strategies and tactics in responding to challenges. To support allocation planning, CDC has also put out guidance outlining a list of critical populations to identify and estimate within each state. These include critical infrastructure workforce, which are healthcare personnel and other essential workers, populations at increased risk of severe illness, which include long-term care facility residents, adults with significant risk factors, populations at risk of acquiring or transmitting COVID-19, and people with limited access to routine vaccination services, which includes individuals in rural or underserved communities. States are utilizing a range of federal and state data and input from partners to define and estimate these populations. Given that healthcare workers will most likely be the first to receive limited allocations of vaccines, states are focusing early efforts on accurately estimating healthcare personnel at high risk of exposure. They are doing this through existing data sources, surveys, and engagement with healthcare systems and provider associations. States have also been provided tools to determine rough estimates of how many vaccine doses they may receive. With this preliminary data, states are identifying how to further prioritize within phase 1 populations when vaccine supply is insufficient to reach all critical populations. So not only do states and territories have to figure out who's in the phase 1A category, but they also have to ensure they're looking at phase 1A, phase 1B, phase 1C. So have a backup plan just in case there's more vaccines or there's not sufficient to reach those initial populations. While many states have already outlined priority populations for initial distribution, many of them have built-in flexibility to adjust to local factors such as provider enrollment, vaccine storage capacity, distribution of critical populations across the states, patterns of disease transmissions, and other factors, which are ongoing factors throughout the delivery of vaccines. Also, as instructed by the CDC, states are also planning to respond to both high and low demand scenarios, which I stated, which states have factored in their allocation decisions. In some places, demand may exceed supply. However, I think one of the biggest concerns that we're seeing with recent polling showing significant levels of hesitancy among healthcare workers, states also need to consider shifting toward distribution to other critical phase 1 populations if there are not enough individuals interested in getting the vaccine. Moving on to enrollment of providers and workforce capacity, which is an issue that states and territories have said is a huge concern. Specifically right now, with the increasing hospitalization cases, many state immunization programs already have a robust network of providers and health systems enrolled as vaccine providers. Provider capacity is another huge issue for states working to expand their workforce of potential vaccine providers. In order to meet these requirements outlined, the CDC has provided provider agreements that providers have to sign. And states are looking at a number of potential vaccinators to expand access to the vaccine in later phases. Several states are examining expanding scope of practice laws or regulations for professionals such as advanced EMTs and paramedics. States have also identified non-traditional providers that could potentially provide surge support. If this weren't complex enough, I know I'm running short on time, so I apologize. The first potential Pfizer vaccine to be approved will require ultra cold storage and also requires 2 doses. I think the majority of the vaccines that the US is looking at will require 2 doses. The Moderna vaccine can be stored at cold temperature, but it will also require 2-dose regimens. So this is an added complexity for states and governors to meet as they're looking at distribution, particular challenges as they need to be transported and stored, utilizing specialized freezers, dry ice, and other equipment. And each shipment, again, is expected to contain a minimum of 975 doses. Pfizer is currently working on shipments with lesser doses to reach more rural areas that don't have the capacity to hold about 975 doses. States have addressed these considerations in varying levels of detail in their plans. And a few states may only distribute ultra cold vaccine in large metro areas during phase 1 and monitor ability to expand as vaccine becomes more widely available. So states and territories are taking a number of different approaches in their delivery. One more thing I want to mention, supply kits which will be shipped directly to provider sites. The kits will not include certain supplies such as sharp containers, gloves, bandages, and additional PPE that some sites may need. States have mentioned that they will need to purchase or have purchased freezers, vaccine storage units, temperature loggers, thermometers, gloves, we're already seeing a shortage of gloves. So I'm very excited to hear about more of the procurement issues from other folks on the call. States are very concerned about the cost of redistribution. Before I end, I just want to emphasize that governors will have to carry out the biggest vaccination plan in history. And there are numerous challenges and outstanding questions complicate state efforts to ensure seamless execution, including clarity on vaccine effectiveness and safety across populations, availability of supply, storage, and handling requirements for specific vaccines, and aligned communication. Lastly, states will need federal resources to carry out their vaccination plan, especially as states maintain their current efforts on testing and other COVID-19 response activities. And also with the number of cases increasing every day, this is a huge issue that NJA is really working on, is additional federal resources for states and territories. Thank you, and I went over my time, I apologize.
Thank you so much, Maribel. Maybe one question that popped up in the chat is that I would like to ask you is, have there been any precautions taken to prevent potential bidding conflicts between the different states?
As you know, I think after what we saw in March, because there was a lot of concern about states competing against each other, states competing against the federal government coming in and sort of taking some of the equipment already ordered by states. States have come into sort of consortiums. So there's consortiums in Northeast and then also on the West Coast where states have come together to purchase some of this supplies and equipment. I think the way the federal government is looking at this is they're providing a lot of what they're saying is the kits that's involved to actually vaccinate. However, what we're seeing, there are lots of concerns with states and territories that this will not be enough, right? What the federal government is providing to states and territories is a minimum. States also will still continue to test. States will still see a huge number of increases of COVID cases, especially during the holidays. So all this on top of a vaccine coming through, states will need to be very concerned about PPE and ensuring that supply chain is out there. With the new administration. We're hearing that President-elect Biden is much more open to using the DPA, the Defense Production Act, which we're hoping that will be the case and will help states in procuring some of this PPE equipment and ensuring that. I think the other issue is does the United States have the manufacturing capability to produce a lot of the PPE that's necessary. So I think there are a number of approaches that states are taking right now. Some have actually stockpiled from earlier on this year.
Thank you so much for answering this question. I would like to now go and switch to our next panelist, Robert Hanfield, Professor of Supply Chain Management at the North Carolina State University. He has co-authored many books on supply chain management. He's a specialist and consulted many Forbes 500 companies. He's also a consulting editor of the Journal of Operations and Management. And I would like to hand over to him now. Thank you.
Thank you, Desiree. So I'm going to try to keep my remarks brief so that we can try to get back on schedule. I've got a couple minutes before the end of my time. I've been working with a lot of different states since early March on the Joint Acquisition Task Force, looking at different issues at the state level and across the country. We've been doing interviews with over 50 chief procurement officers in different states across the country as well to get a sense of how they're doing. Just in general, there's been a lot of lessons learned since early March on preparation and how to be and how to prepare for it. We actually have a webinar scheduled on December 16th where we will go into a lot more depth into each of the potential bottlenecks that could emerge during the COVID crisis and during the vaccine deployment. I will note that the CDC, as part of Operational Warp Speed, note that the only anticipated supply shortage will be during phase 1, during the initial growth of demand for vaccines. As a supply chain professional, I'm not so optimistic, and they assume that likely supply will be sufficient to meet demand during phase 2 and phase 3. What we've done a more in-depth analysis using the SCORE model of plan, source, make, deliver, and sell. And I'll go briefly into what each of those are. And we really see bottlenecks that are potentially likely to arise in each one of those areas of the supply chain. The first around planning, we believe there's going to be challenges with allocation, how those waves of distribution will be allocated, where to position inventory. And we foresee a big problem is actually tracking how people are going to get the second dose of the vaccine. And we think a digital solution would really help with that. There's also significant risks. There's already been detected hacking. There's the loss of a potential IP loss, a lack of coordination, even terrorism or nation state sabotage. These are all real possibilities. The vaccine has been described as liquid gold, and whenever you have that situation, you have the potential for nefarious activities to take place. The issue of coordination is one I think that's significant. None of the states I've spoken with have had any really very solid communications with warp speed. So it really has not been laid out as to how distribution is going to occur. In terms of the source, we think there's bottlenecks. These include stoppers, adjuvants, cold storage, lipids, raw materials for syringes and stoppers. During the make phase of actually the production, fill finish capacity is right-sized for normal times. They're not right-sized for a massive surge in the fill finish, which is the process that's used to fill the capsules with the vaccine product. And in the production of the equipment that's needed to expand this is also significantly limited. The deliver issue that's been alluded to by Maribel. Cold chain logistics capacity is very limited. There's very little information yet about how the vaccines will be carried, especially to remote areas. We've identified some interesting technologies like these cold storage. They're literally big containers that have cryo capabilities to be able to keep it at a temperature of 80 below zero. And if you could get one of those in the back of a truck, you might be able to move it to these very remote areas. And that's a challenge in a country as large as the US. There's a lot of these very remote areas. And then I talk about sell and return. Not everybody wants to get a vaccine. So we have one of our faculty at NC State who's working with some of the people in DHHS on how to do a marketing campaign to try to convince people to take the vaccine. Nowhere else in the world is this a problem, but in the US, of course, where people refuse to get a vaccine and don't trust it. And this is particularly true in some of the low income areas, as well as other areas where there's misinformation. And then finally, the issue of return. The collection and disposal of the syringes will be a massive task. How to safely collect and dispose of those materials is going to be a big challenge. So I'll wrap it up with that. And then if again, we're going to be going into more detail on this in our webinar next week. And I've posted a link to that in the chat if anyone's interested. Thank you.
Thank you so much, Rob, also for posting the link. Very interesting webinar next week. Now I would like to wrap up the United States part of our webinar. Of course, we can come back to questions at the end of the webinar and switch over to the international part. Our first panelist on this matter is Professor Simon Evenet. He's Professor for International Trade and Economic Development and MBA Director at the University of St. Gallen, Switzerland. He created the Global Trade Alert Initiative, the leading independent monitor of protectionism and commercial policy choice. He has also served as World Bank official twice, and I am very excited to hear what he has to say about export control and hand over now. Thank you.
Thank you, Desiree, for that introduction, and good morning, everybody in the US. I will make 4 brief points highlighting different international trade aspects which will bear upon the global distribution of vaccines. The first point is to recognize that according to the WTO's tariff download facility, at this time, there are 28 nations which tax the importation of human vaccines. And 2 of those nations tax imported vaccines at 10% of value. The countries in question are India and the Congo. What these taxes will do essentially, of course, means that governments will essentially profit from the distribution of these vaccines. And of course, the right policy response is to waive or temporarily suspend these tariffs. But it's remarkable that even at this stage, we still have governments with tariffs on human vaccines in place. The second piece of evidence I want to bring to the table draws from the Global Trade Alert database, where I looked this morning into the public policies which are currently in force as of today, which have been accumulating over the last 10 years in the area of human vaccines. The good news is that over the last 10 years, we have seen 72 trade reforms, 19 of which took place this year. So governments have begun to ease the trade in human vaccines. But the bad news is that on the other side of the ledger, there are 76 trade distortions which have been put in place over the last 10 years, which are in effect, 4 of them, by the way, relate to public procurement practices, which may be of interest to this crowd. And 13 of those trade distortions have been introduced this year. The worst year for introducing trade distortions in human vaccines was 2015, when there were 15 such distortions put in place. So the takeaway there is that the cross-border movement of vaccines does indeed run into potential trade barriers, and these, of course, are barriers which should be removed if we're going to seamlessly distribute vaccine in the years ahead. In the year ahead, I should say. The third important factor that I want to raise is a discussion at the World Trade Organization in response to a proposal by India and South Africa. This proposal of India and South Africa is to waive certain elements of the World Trade Organization's agreement on intellectual property, and specifically to allow countries to be able to compulsorily license and produce vaccines. And let's not get into the details unless people want to about the various provisions involved. But this proposal, of course, follows many other discussions we've had at the WTO on what's the appropriate set of international trade rules for human vaccines. And this proposal has met opposition from mainly the industrialized world, and a group of 4 industrialized countries have put forward a paper asking a list of 8 questions, which really come down to the question, to what extent are the current intellectual property rights rules really an impediment to the distribution of these vaccines, and to what extent are the problems in certain countries with respect to distribution more a function of inefficient procurement regimes, inefficient health regimes, and also difficulties in cross-border shipment and also intranational shipment as well. So that's another emergent area to watch. It could be a potential source of tension as we go forward. The last area I want to raise is one which Robert has already talked a bit about, and that is the potential for hold-up problems as we scale up production in vaccines and then come to distribute them. And here the hold-up problems could occur in 2 ways. We could have countries where production is taking place suddenly banning the export of vaccines to countries, even to those countries which have paid for those vaccines. And of course, there is the sort of overhanging threat that we've heard from the Trump administration that they would contemplate doing so as well. So it will be an interesting question whether or not we will see export bans on vaccines produced. And of course, earlier this year, we saw many export bans put in place in the context of PPE and other medical equipment. And there was very little in terms of international restraint in this respect. Fortunately, many governments realized that these policies were counterproductive in a world of supply chains. But in the case of vaccines, the issue here may be so politically sensitive that export bans may re-emerge. The other area where I think we have to be open to the potential for hold up is in the supplies of which go into producing these vaccines, and also the accessories necessary to deliver and inject people with vaccines. And we've just heard the list from Robert of the potential products in this respect. And I think an interesting question is whether or not countries which are exporting these particular items may ban exports in order to secure commitments for greater final vaccine delivery from the manufacturers of those goods. And that will lead, I think, to potential trade tensions next year. Ultimately, when we look from a global perspective, the very fact that there appears to be a mismatch between the total needs for vaccination next year and the total levels being produced or envisaged for production means that there's going to be a lot of governments and people around the world who are waiting for vaccines who won't get them. And this is not likely to be a recipe for sound, sensible government policy. We're likely to get some extraordinary reactions in this area. So I think the international dimension poses a number of challenges, and this, of course, augments all the observations made by our colleagues earlier about the challenges within nations. So the intranational and the international challenges both will have to be taken into account. Thank you very much.
Thank you so much, Simon, for this very interesting field of export controls and what to do in a public health emergency and what not to do. I would like now to introduce our next panelist, Prashanth Yadav. He's a senior fellow at the Center for Global Development, which is a think tank based in Washington, D.C. and London. He's also an affiliate professor at INSEAD, and he focuses on improving healthcare supply chains and supply chains for products with social benefits. He has recently published an article on equitable distribution of COVID vaccine in a Harvard Business Review, and has given an interview on how the distribution infrastructure will deploy the coronavirus vaccine. Thank you so much for being here today, and I hand over.
Thank you, Desiree, and thanks everyone. Thank you for Chris and others who've been involved in organizing this excellent webinar. I want to talk about three things. First, I want to stress, and I heard just some part of what Simon was mentioning. I think we've got to start with, do we have enough supplies, and what can we do to enhance manufacturing capacity, both capacity and manufacturing throughput? And that leads to multiple questions, some of which are about scale up, scale out models, such as, can we have additional manufacturing capacity for successful vaccine candidates in multiple locations? This gets into issues related to decentralized manufacturing. What are the economies of scale that are compromised by doing decentralized manufacturing? Is it feasible for certain platforms even to do it? So that's one part. And then there are also IP related issues connected to that. But whatever we can do to expand total manufacturing capacity, we then don't have to face these difficult decisions about how to allocate. And yes, we can put a lot more science and a lot more ethics into deciding how to allocate scarce stock. But a better problem to have would be to work with a larger amount of supplies to start with. And that is feasible, but requires, concerted thinking. Embedded within that is the idea that if you look at the aggregate, we may have sufficient capacity. But when we disaggregate that, we don't. What I mean by that is, not every manufacturing site and every vaccine sponsor are optimally connected. Same thing is, not all manufacturing locations are completely reconfigurable. So imagine the scenario, there are two vaccines, one of which succeeds with a very high efficacy and very strong safety data, and the other comes out even lower than the WHO set threshold on efficacy. We want to reconfigure everything that was set up for the vaccine which did not achieve our desired success parameters to go towards the ones that did. And that fungibility and reconfiguration ability of capacity is harder to achieve because manufacturing assets are controlled by vaccine sponsors, and they are willing, but not as quickly as we would like them to. So we are seeing that government involvement in manufacturing, which can be both a good thing and a bad thing. It's a good thing in the sense that if there is a central agency that owns the contracts for many of the manufacturing components, they will be most interested in ensuring what can society get as maximum throughput and how do we reconfigure them. Some of it is happening naturally now because many of the vaccine sponsors have chosen the same contract manufacturers, and the same contract manufacturer has one production suite in the same larger facility for company A, another production suite for company B. And if company B's vaccine for some reason doesn't take off, doesn't meet the required targets, then they can reconfigure those two suites. So some of it has happened by the market naturally. Some requires concerted action. And that's an element we don't think about. And then the same is true of auxiliary supplies. So if vaccine manufacturer A has stockpiled 500 million dose equivalent vials, 500 dose million equivalent excipients and other items that are needed, adjuvants, many other things, but their vaccine fails, we want to quickly take all those supplies and put them for the vaccine manufacturer, which has succeeded. And will that function happen through the market mechanism naturally? Maybe. Does that function require the role of a central orchestrator of the supply chain? That's my opinion. Kovacs, CEPI are to some extent playing that role, not necessarily mandated to play it, but because there is a gap in the market, they're starting to play it, but much more needs to happen to think about that for the whole market, not just for subcomponents of the market. So that's one part. Need for an orchestrator for manufacturing capacity and for auxiliary supplies. Auxiliary supplies such as syringes are also things that we don't usually fly on a plane. So yes, Simon is right that there are countries who are large manufacturing countries and may put trade embargoes in case they become scarce. But syringes are largely air and plastic, and they are not the kind of density that we would put in a plane. I mean, vaccine vials, we are going to fly around. We'll fly them in, cargo planes, freighter planes, Air Force planes, whatever will come our way. But syringes, we need to think about putting them closer to where the demand centers are. So if manufacturing for syringes is occurring in 5 major hubs in the world, we should already start pre-positioning inventory of syringes closer to where they will go, because we have the luxury of at least a couple of months of time before large-scale supplies start going to developing country destinations. So that's on auxiliary supplies. Matching the two together has been a challenge every time we've tried to do it, which means a health clinic, a country, a district receives too much vials, too few syringes, or too many syringes, not equivalent vials, right? So synchronously matching the quantity and timing of arrival of vaccine vials with auxiliary supplies is a complex informational challenge, which we haven't succeeded sometimes in the past. So I do worry about it a little bit and want to flag to people that it should get enough attention. Then the second thing I want to talk about is that a lot is uncertain about what will come to the country, and we are asking country supply chains to get ready. Right? So we're saying, why aren't countries getting ready with their in-country supply chains for vaccination? But they don't know what is coming their way. And that is understandable because vaccines have not been approved yet. The second uncertainty is that if I'm a low and middle income country, I have signed up for Kovacs. So I will get 3% and 20% of my supplies over time from Kovacs. But then the rest of it, I will try to get from somewhere else. And I'm not clear if Kovacs will give me only one type of vaccine, given their contracts, or they will give me one or two, and then I'm negotiating a deal on the side for another. And then so what will come in my supply chain will be 3 different types of vaccines, maybe. And that's a complexity that a supply chain doesn't like. Every time we've tried to do this with malaria, HIV, when we have multiple first-line therapies, the cost of complexity grows not only the supply chain, but even operationally, the person who has to administer a vaccine now has to know this one uses a diluent. So they have to develop this muscle memory, because that quickly you can't refer to a standard operating procedure run by the checklist, etc. So that's the challenge. And I'm not saying we should just focus on one vaccine for one country, but I'm saying all of this requires very strong information infrastructure to be built. And then there are investments in infrastructure which are what I would call as almost no regrets investments, because no matter what happens to a country's COVID-19 vaccination program, right? There are many low-income countries who are saying our caseload is low. Middle-income countries is different. India, Brazil is a different matter. But many low-income countries are saying we don't have that much, that intensity of infection. So yes, we will vaccinate, but this is not in the kinds that have been talked about for India, Brazil, or some other countries. So there, they want to think about having a well-functioning system, which is not just for COVID-19 vaccine, but what things can be used for other programs, whether it is routine immunization or, equally importantly, for a future pathogen and preparedness of the supply chain to take on something else that comes. And this is where this debate about whether nucleic acid vaccines, and in particular messenger RNA vaccines, are suitable for developing countries or not, because they require, at this time, they require somewhat more resource-intensive cold chains. We have, in looking at that, we have to keep in mind that if the messenger RNA technology is as versatile as we've heard it is, and now it's proven to be commercially and clinically successful, then we do want multiple developing countries to have access to this technology, not just for COVID-19, but whatever future pathogens comes, if this is our fastest way to get to a vaccine. So saying the messenger RNA is the rich country vaccine and other sort of vaccines are the poor country vaccines isn't thinking about the future beyond COVID. But if we think about it right, we can create platforms for delivering newer vaccines, perhaps even larger, more expanded manufacturing networks. And we learn about the thermostability of these products over time. So let's not assume what we know today is what will remain the state of our knowledge in the next few years. And then I want to talk about data and tools. So think about primary packaging. I mean, I want to use a simple example to illustrate why data and technology becomes important. So think about primary packaging. Primary packaging implying how many doses you fill in a vial. Yeah, we have variants from 2 up to 20, 2, 5, 2, 5, 10, 20. So if you are a really small health clinic in rural Namibia, or perhaps even rural Australia, you don't want to get that 1,000 dose carry box, because in a week, you don't vaccinate 1,000 people in rural Namibia or in rural Australia. The walk-in rates are very small or low. But if you're in New Delhi, India, or if you're in Lagos, Nigeria, yes, you can use that quickly, right? And that's not just by country and city, it's also facility by facility. Some health facilities get much faster turnaround, some get smaller. So we need to start thinking about matching primary, secondary packaging, and secondary implying the box in which you put multiple vials, to the kinds of facilities. And this can be done with the data. We have enough tools and data to solve this problem effectively. And there are companies, one of them being MacroEyes, which I work with. But we have the tools to solve this. We just need to create the overall ecosystem for the supply chain to say, here are the data elements we can get. Here is where we can put advanced computing to use. And here is where we will still need human ingenuity to be the way, such as, in the US, we are still talking about a vaccination card, which is a paper-based vaccination card. And because that's maybe our way to, and bringing those three together is extremely important. But there are multiple tools that are coming out about preparedness, country cold chain capacity assessment, etc., which are all very well structured. But what I'm asking for is something simpler, which is not another complex tool, but something which just allows us to connect these different pieces together and say, if I'm a country, I want to see a true picture of if this is what I get, these are different types, here is how my program planning will work, and I know my asset infrastructure weaknesses, I know my asset strength. And then the last thing I want to mention is that especially in some middle-income countries, we tend to think that the childhood vaccination program is very public sector focused, which is true, and therefore we should use that as the exclusive platform for COVID-19 vaccine. The reality is that adults don't go to public sector. The private sector does serve as a source for healthcare for lots of people, including the poorest of the poor. And if we really want to reach them, we do need to work and create a supply chain that can serve private clinics, which are at the base of the pyramid, that serve people who are in urban slums, that serve people who are rural poor, but go to private sector because public sector hasn't traditionally served them well. But that function, once again, relies on an information backbone that will give the government the confidence that if we put our scarce supply of just a few million doses of vaccine that we get in the first round into the private sector, we will learn and be confident about where it's going, who's getting it, etc. So that information backbone is something that requires, it requires investment and effort, which hasn't happened yet. And we can build off of what we have in the public sector for the under 5 or the children's immunization programs, but it will require something else on top of that to include the private sector nodes into it. And that would be the last thing I would flag for an area that needs to be addressed. Thank you.
Thank you so much, Prashanth, for this very interesting overview and insight, especially about the data and the matching. I think this is a key part of how we can succeed with the distribution. I would now like to go to our last panelist, Steve Guppy, Crown Agent. And so he's the director of procurement at Crown Agents, an international development company specializing in international procurement and supply chain. He's working for the Crown Agents for 30 years in many countries in Africa and Asia. He's the supportive proponent of integrity and transparency with the supply chain. He will provide some insights into the Kovacs Alliance and talk about readiness and planning, as well as cold supply chain. I'm happy to hand over to him before we go over to our last part, the questions, where we will be very selective. Thank you.
Thank you, Desiree, and what a great session this has been so far. So hopefully I don't let the side down with the last part of it. So I think, as Bill Gates said in a recent article, the world needs 3 things right now. It needs the capacity to produce billions of doses of vaccines, the funding to pay for it, and the systems to deliver it. So I think, we're at a point now we're saying the science has done its job to get vaccines to us. The spotlight is now on the supply chain to deliver. And I think we mean literally deliver. So as a practitioner in this field, I'm both excited and slightly terrified at the task at hand. But I think what we're clear is that we do not want the story that the next generation tells to be the one where the scientists and the laboratories did their work, but the supply chain was the weakest link. So before I give some of my thoughts on some of those areas that we need to pay attention to, and building on some of the things that we've already heard in terms of the supply chain ecosystem that Prashanth's mentioned, I was asked to give a quick overview of the Kovacs facility because it's been mentioned a few times already in this webinar. And so just to make sure that everyone is on the same page with that, we've provided a quick link in the resources page of the web page accompanying this webinar. But I'll give a very quick introduction to what it is. So this facility, as Amanda mentioned, is co-led by the WHO, the Coalition for Epidemic Preparedness Innovations, and Gavi, the Vaccine Alliance. And essentially its aim is to provide equitable access to the vaccines, ensuring that people in all corners of the world will get it, rather than just the wealthy countries dominating and monopolizing the supply. I'm sure we all are desperate to avoid the situation that we all faced and we saw earlier this year in the race for ventilators and PPE and those issues that were mentioned before, when we saw what can happen when there is a sudden demand surge which creates a huge supply chain disruption. Whereas that was an unexpected emergency situation, as Prashanth has said, the supply and distribution of vaccines is not currently an emergency supply chain surge situation. We know this is coming. We've got time to prepare. And we need to make sure there are better systems and better, stronger coordination points in order to make that happen. And that's what the Kovacs pillar essentially has been designed to do. It enables both self-financing economies and funded economies to participate in this process. So through something called the Advanced Market Commitment, there is support to lower and middle income countries. So 92 lower and middle income countries and economies are able to access the vaccines through this Advanced Market Commitment. In addition to that, 90 self-financing countries have also signed up. So all of these participating countries, regardless of their income levels, will have access to vaccines. The funded countries will receive enough doses, as Prashanth said, to vaccinate potentially up to 20% of their population at some point in time. But since demand is obviously initially likely to exceed the supply, an allocation framework is being developed by the WHO to look at the equitable distribution of these. What is, however, important to note is that Kovacs, as brilliant as it is not, as far as we're aware, going to go down to last mile distribution, and neither will it cover the entire need of a country, as has been mentioned already. So, as I said, there are lots more links and lots more information about Kovacs and how it works if you're interested in that. But it's a really important way forward and an excellent initiative that we're all supporting. What I want to move us on to now is there's some of those preparedness and readiness aspects that we've mentioned before, and building on what Prashanth has already said. I think Toby Peters, the Professor of Cold Chain Economy from the University of Birmingham here in the UK, has called this the biggest logistical challenge the world has ever seen. Quite a statement. And the regional director for WHO in Africa has said that planning and preparation will make or break this unprecedented endeavour. I think all things that we resonate with. In mid-November, the WHO and UNICEF published its guidance on developing national deployment and vaccination plans for COVID vaccines. This guides national governments in developing and updating their national deployment and vaccination plan. In that document, it's quite clear. Supply chain readiness is key to efficiently deploying the vaccines to the target populations. We've also seen the WHO and the UNICEF VIRAT tool, which is an assessment tool, which helps with 57 different indicators spanning 10 different categories of readiness, including things like the regulatory landscape, the issues that Simon's mentioned, monitoring and evaluation, and how to train people in using of the vaccines. We also have the World Bank Readiness Assessment Framework, the VRAF, which is complementary to that. And we know that readiness assessment is underway in a large number of countries across the world. But we also know that there's been this call for ramping up readiness from the WHO recently. And notwithstanding the issues that Prashanth so correctly identified, is how do you get ready for something when you don't know what that something is? I think there are still some areas that we can possibly look at, and some things that we're seeing in our work across the world in the supply chain environment. I only have time to look at two of these very briefly, and there are many, many more obviously that we could touch on. But the two that I wanted to look at are the temperature control areas and the security of the supply chain. So when I'm talking about temperature control, I'm not just talking about the ultra cold vaccine chain that we've heard of, you know, those ultra cold temperatures, but of course, cold chain is an essential part of any pharmaceutical supply chain. And if there are any silver linings to this pandemic, I wonder if one of those is that we are now being forced to develop more innovative approaches to temperature controls, especially across Africa and Asia, where we know those daytime temperatures reach incredibly high numbers, and in Middle East and Caribbean, where we've got issues of heat and humidity as well. So a lot of work has already been done in solar fridge technology. Solar powered fridges and freezers are going to be essential. And as they become smaller and more efficient, and the weight of them and the size of them become smaller, they may well be a solution for remote parts of the world where we can actually hand carry them if necessary. A lot of them now have data connectivity inside them to enable remote monitoring of the vaccines. So again, some really great ideas that are coming through in the industry there. For example, in South Sudan, where we're doing a lot of work, and one of the least electrified companies of the world, UNICEF has installed solar fridges now in more than 7,000 health facilities. And it says that it's going to submit 65,000 more solar fridges around the world within the next few months. Now, I do wonder, without the COVID pandemic, how long would it have taken us to have get to that system, to that level? And is there some sort of situation whereby the pandemic perversely has acted as a much needed accelerator in strengthening cold chain capacity globally for vaccines? Similarly, I'm hopeful that we'll now start to see a real greater use of other technology, such as things like smarter data loggers, these units which are constantly recording temperature real time inside boxes and using alert systems and transmitting data back through mobile app technologies where deviations are being recorded. Again, these are already in play and we're seeing them in our warehouses in Sierra Leone. And having that real-time access to data on your mobile phone is hugely important when you get issues of supply chain, so cold chain disturbances, so you can take immediate actions. But again, is this an idea that we can now push forward on and actually promote a lot quicker because of the need that's coming up? So it's one thing there that's just really important in terms of the temperature aspects of it. And then, as I say, not just related to the ultra cold chain, it applies, as Prashanth said, to developing the backbone of an ecosystem that will last us for future years. Now, the other point I mentioned was supply chain security. Now, Rob's already touched on some of these points about hacking and other things that are a challenge. I think what we're looking at the moment in some countries that we're working in is the security of the product through tracking and tracing technology. And that's going to be key if we are going to avoid counterfeiting and theft. I think the term liquid gold was used earlier in this webinar, and I think that's exactly some of the challenges that we're seeing that some governments are now worrying about. How do they protect the supply chain when these vaccines are actually arriving in country? And that may be an issue as well in the US as it is for some of the LMICs. The World Bank, the WHO guidance I mentioned earlier spoke on this issue in that document, saying that steps need to be taken to improve the supply chain system to facilitate track and trace capabilities, and a plan to ensure security and authenticity of supply is absolutely critical. The WHO guidance on traceability does contain information about the key considerations when trying to get a traceability system in for health products. The last point I just want to make before we move on to the important Q&A is that things like drone delivery are also being looked at for those hard to reach situations. But again, are the current security measures with drone technology enough to make them fully secure for a supply chain operation? And is this an opportunity to push that thinking and technology forward at a fast-paced and a fast-forward approach? As I said, there are many other areas of readiness and preparedness that we could get into right now, such as hard infrastructure or flattening the supply chain to reduce numbers of touch points. But I'll stop here as I believe we're now keen to get into the Q&A part of this webinar. Thank you very much.
Thank you so much, Steve. This was a very interesting insight into Kovacs and readiness and preparedness that plays an important role in future distribution in an international level. I would like to pick up one question that we got from the audience, which is from Ronald Perlman. And he asks, are the mandates of the FAR, which is the Federal Acquisition Regulation, in the United States for competition being followed in connection with acquisition of vaccines or logistic distributions? And I would like to ask that to our host, Chris Ukins.
So that's a two-level question, Desiree. One question would be the contracting that occurred at the federal level for the vaccines, and the second would be the contracting that's occurring at the state and local level. We have a number of state and local procurement officials who joined us here today, and the type of procurement they'll need to do in order to distribute the vaccine. So at I want to focus on the state and local level right now, just because that's the most imperative, because the vaccine distribution is in process. At the state and local level, there's a great deal of flexibility in the state and local procurement codes that allow for basically emergency procurement for in exigent circumstances to shortcut competition and transparency. And so that is an important flexibility. And for our colleagues, we also have colleagues from around the world who are procurement officials. For purposes of vaccine distribution, it's very important to ensure that there is that flexibility in the procurement rules so that the procurement officials can respond flexibly, quickly to what are, as all our panelists have pointed out, to a very tumultuous situation potentially as we try to get as many vaccines out to as many people as quickly as possible. Just quickly for me, I'm just going to ask the indulgence of the audience if we could go until 15 minutes past the hour. I appreciate it. I know we've gone over time, but I think we have some important questions pending. And Desiree, I'll leave that to you.
Thank you so much. I think we should answer a couple of more questions, as you pointed out, but of course people are free to leave, but I think they're very important questions. And one is coming from Suala Varmate, and this person is asking, are there strategies and tools to share with countries where corruption is an ever-present risk so that it does not create huge hindrance in such countries? I think this is a very valid question of corruption, and I would like to, there are different panelists. Is there someone who would like to pick up that question right away? Otherwise, I would ask someone in specific.
I just want to thank Suala for the question. He's a student of mine at the UN facility, United Nations facility in Turin. Thank you very much for the question. I'll leave it to the other panelists if they'd like to address this corruption issue.
I mean, Desiree, I'm happy to sort of respond in terms of, are there strategies and tools in terms of anti-corruption? Yes, there are lots. There are lots of reports. There are lots of studies on the causes of corruption, on the, you know, how we can try and avoid it in a supply chain context. I think, you know, in terms of this particular area of the vaccine supply chain, I think, you know, we're very clear, as was mentioned, you know, it's going to be liquid gold. There is going to be a risk. So it's all about risk management and reducing the opportunities for that type of behavior to occur in this situation. And I think one of those areas is probably flattening the supply chain, which I mentioned briefly in terms of having less touch points on the whole process. So the more that the flatter your supply chain is, the less points it moves through, the less opportunities there are for things to actually disappear or you know, other aspects of loss in the supply chain. And then when you're looking at sort of corruption in another angle, you could be looking at it from overinflated prices and other things, which we've seen all horror stories around in terms of that over the last sort of few weeks and months coming out from all sides of the world. So there's lots and lots of work being done academically and in practice in terms of anti-corruption in public procurement. Yeah.
Thank you very much. I would like to ask one question that we have on our question slide, but I think it's very important to ask is, are there lessons we can draw from the distribution and administration of Ebola vaccine and anti-HIV efforts? I think we can learn important lessons from this, and maybe Steve or Amanda can talk about or to this question.
I think Steve can speak from our experience, Carnage's experience responding to Ebola.
Sorry, Desiree, could you repeat the question? I'm having a few
of course
IT challenges
so
with my
on
speaker.
our question slide, and is are there lessons that we can draw from the distribution and administration of the Ebola vaccine and the anti-HIV efforts? And Amanda asked you to elaborate on the Ebola part.
I mean, yes, in a nutshell, there are. I think, you know, in DRC, particularly during Ebola, it was proven that you can distribute ultra low cold chain supply chains in that context. And I think there are lots of lessons that are being looked at from how Ebola was handled. So yes, there are studies, and obviously people are looking into that. That's a very recent in living memory situation. I think the HIV challenges that came out in terms of, you know, making sure Africa wasn't left behind in terms of HIV, and I think the story is that it probably was. And that really, the lesson learned from there is one which Kovacs is trying to eliminate, which is, you know, equal access to everything for everybody. So yes, there's lots of lessons, probably too many to go into in this webinar, but certainly that's being looked at, and lots of people are making sure that those lessons are learned well.
And Desiree, maybe just to complement what Steve said, I think one of the very exciting developments will come with the incoming Biden administration and re-engagement with the international community and specifically the WHO. So far, from what I've heard, we haven't heard any direct statements on the re-engagement with Kovacs specifically, but I am convinced that the US is going to come into the new year leading the charge and providing a much greater amount of global support and a much less exclusionary stance toward distribution of the vaccine. I think we'll see a moving away from Americans only, America first, to really a global response with US leadership under a Biden administration.
Thank you so much for answering this question. I would like to ask one last question to round up our webinar and to close the loop to public procurement. Namely, will there be a role for public procurement to close gaps in the distribution of vaccines? I think this is a very central and crucial question, and I would like to pose that to our panelists in general first, if someone has an opinion on that question.
So if I could actually to pass the question to Maribel from the perspective of the governors, Maribel, have you seen over the first stages of the pandemic in responding in the United States to the pandemic and to the supply chain issues, have you seen a closer coordination between the public procurement community, the public procurement officials, and the governors in order to make the response to the pandemic more effective? Because I think that's an important part of understanding what the role of public procurement will be going forward.
Yes, I definitely think that has improved since March. Again, states and governors were sort of forced to do this on their own. Not a lot of coordination at the top. So states and governors had to jump in and figure out how to address a lot of these supply chain issues for their states and individuals in their states. So yes, we believe that has improved a little bit. However, there are still lots of concerns, I think, coming in from states to ensure that the supply is there. So hopefully that answers your question.
I just make another point, Chris. There was another excellent question that someone made that, how are we taking into account the spillage to be expected when using multi-dose vials and the losses due to cold chain integrity issues? This is an excellent point. We think that there could be as much as 5% of the doses that, could go to waste. And the danger, of course, is that ends up, in the black market if it's not disposed of properly as well. And that would endanger people as well if it's past an expiration date or it's not maintained in that integrity of the cold chain. So those are significant risks that exist at the moment.
Indeed, and I think that's where the track and trace aspects of this come in so clearly, isn't it? To be able to actually trace where the vaccine has been and whether it has been sort of injected or whether it has been disposed of, and then disposal as a part of public procurement, as a part of a supply chain, is an ongoing conversation anyway, isn't it? The safe disposal of product and how you collect that and dispose of it. So yeah, I totally agree with you.
Yeah, and I would add for states, as far as like the redistribution issue is huge because of the number of vials that are being delivered. Some more rural parts of the states won't be able to utilize that quantity. So what we're seeing is that some states are, with the Pfizer vaccine, are prioritizing areas that have the capacity and then waiting to potentially for Moderna or other vaccines to come on the market to vaccinate or to provide vaccinations for more rural parts of the states.
I think that whole issue of reverse logistics is going to be a big one.
Okay, I think we've reached the end of our time. Desiree, you've done a fantastic job. Thanks very much for being a co-moderator. We really appreciate it. Thank you as well to all the panelists and to all of our participants who've asked incredibly interesting questions. I think this has been a really very, very useful webinar. As I said, it's going to be said earlier, it's going to be posted on the program page of Public Procurement International. We'll be posting the YouTube recording within the next few hours. But again, thank you very much, and thank you for joining us at this important stage in the pandemic as we begin to walk the road back. Thank you.